confused with pituitary adenoma. Okay, why is that, folks? When we say pituitary adenoma, we think of prolactinoma. So how do we call this? This is a non-functional pituitary adenoma. Is everybody clear? Craniopharyngioma is called non-functional pituitary adenoma because both causes bitemporal hemianapsia. This is the one that comes more on the exam with bitemporal hemianapsia, folks. I'll tell you a recent exam question exactly where. This is a truck driver, and recently the truck driver noticed when he wanted to change the lane on the highway, he has to turn and see completely to see if there's any vehicle on the track, in the lane, next lane. When you drive, your peripheral vision sees what's on the right side or left side of your driving, isn't it, folks? But when you have a bitemporal hemianapsia, what happened? You have to turn this way because you don't have a peripheral vision. Is that clear, folks? So that's how they are trying to bring it, okay? Associated with high recurrence rate, folks, okay? So they asked that. This is another disease that has bimodal distribution. What is bimodal distribution? Either it happens in very young kids or it happens in very older people, folks, okay? So that's bimodal distribution. They continue to ask, it's derived from remnants of Rathke's pouch ectoderm. Remnant of Rathke's pouch. This is the only reason you need to remember this name, Rathke's pouch. So remnant, calcification is common. That brings you the answer. Once your gland is calcified, you cannot produce anything, can you? All right. So that's craniopharyngioma. Next one, pineal gland tumor. What did we say the function of pineal gland? It produces melatonin. Now, if you have a tumor, you're going to have excess amount of melatonin. Excess amount of melatonin. Most commonly, is an extragonadal germ cell tumor, increased incidence in male. Presents with obstructive hydrocephalus because it compresses cerebral aqueduct. If it compresses cerebral aqueduct, what are the ventricle will be enlarged? We did a question. Exactly the same question. Lateral and third will be enlarged. Is that clear, folks? Lateral and third will be enlarged. I want you guys to highlight Perinaut syndrome. Now, most likely on Monday, the last topic of neuro before pharm is your brainstem lesion. Okay. That's my last topic because you cannot learn that unless you finish everything in neuro because brainstem lesion involve every single thing, folks. Most difficult lesion to learn in entire neurology. There's about 6 diseases we need to learn. These are the disorder of medulla oblongata, pons, midbrain, very critical, right? So we will learn as a last topic of neuro. One of the 6 lesions of brainstem is Perinaut syndrome. One of them is Perinaut syndrome, okay? So I will talk about that later there. Okay, so that's the idea. So when we do Perinaut syndrome in brainstem lesion, I will ask you what causes Perinaut syndrome. The answer is pineal gland tumor. Is that clear, folks? So what happens is when the pineal gland is like this and the tumor, they enlarge, they compress something. That compression of the brainstem give you Perinaut syndrome. Is that clear, folks? All right. So we'll talk about that. I will remember, and we will discuss further in there, folks. Okay. Very important. That's pineal gland tumor. These are all childhood primary brain tumors. Is everybody clear? All right. Let's continue. I'll come to herniation later. This herniation is also associated with brainstem. Okay, that's where the problem comes. Herniation causes brainstem lesions. We'll come to that. Let's go. One of the most important topic, we need to take care of it. Bell's palsy. Bell's palsy. %1 question in your exam, and you have to be extremely careful. Now, Let's take a look at the normal physiology or the anatomy of face. So we divide the face into half, okay? One half. So we're going to say that's the right side of the patient. This is the left side of the patient. We divide further that into upper half and lower half. So we're going to say upper and this is lower. Is everybody clear, folks? Upper half means basically anything above the eye. Lower half means anything below the eye. Now I want you to follow me here. From here, we call it's a nerve. From there, the nerve, okay? Because in this picture, they are showing the whole nucleus and pathway and stuff, right? Now, if you remember facial nerve, the facial nerve comes and they come out through a foramen here, isn't it, folks? Anybody knows the name of the foramen? It's a stylohyoid foramina. They won't ask you in the exam. So once the nerve comes out of that foramina, we call that facial nerve. Is that clear, folks? So once facial nerve comes out, they innervate the entire half of the face. Is everybody clear, folks? Then you should know that facial nerve actually has two fibers. One for the upper face and the other one for the lower face. Is that clear, folks? Okay, now let me clean this up. You could see here. Look at that. Facial nerve comes, there's one fiber that goes to the upper part of the face, then one fiber that goes to the lower part of the face. So if I am holding facial nerve in my hand, I am holding both fibers together. Is that clear, folks? Now, whenever there is a damage to the facial nerve, I'm writing that. Whenever there is a damage to the facial nerve, we call this lower motor lesion. Now, please forget upper motor and lower motor, what we studied in spinal cord. That does not apply here. So what we studied, upper motor lesion and lower motor lesion on the spinal cord, remember that, folks? That is only specific for peripheral nerves and spinal cord. Here is face. We are above spinal cord. Is everybody clear, folks? So that rules don't apply here. So in face, we call lower motor lesion when the nerve is actually involved. Is that crystal clear, folks? Are you guys following me? Okay, I repeat, we only call it lower motor lesion when the actual nerve is involved, because these are cranial nerves. So we are only talking about facial nerve. So if I say a question, facial nerve is compressed, that's a lower motor lesion because it's the actual nerve that's compressed. Is that clear, folks? When the facial nerve is compressed, entire half will be gone because the nerve control both fiber, upper and lower. The whole half face will be affected. Is that clear? Okay. So that's that. Now, if I go further before the nerve, that's a nucleus. Now look at this, folks. There's something called facial nucleus. They send fiber, one fiber to the lower half of the face, and they send another fiber to the upper half of the face. Is everybody clear, folks? But I want you guys to keep an eye on here. The lower half of the face only get one signal. You see that? From the brain nucleus, they only get one signal. But when it comes to upper half of the face, they get two signals, one from the opposite side and one from the same side. Do you see that, folks? Are you guys following me? So technically, I could tell the upper part of the face get two fibers, lower part of the face get only one fiber. Is everybody clear, folks? Now look at that. It shows, right? This is the upper part of the nerve that comes out, but you have two fibers coming in, one from the opposite side, one from the same side. Are we clear, folks? All right. Now, earlier I was telling, if the entire half of the face is gone, that means the entire nerve is affected. That's why it's connecting both, right? Imagine, folks, if I were to have a lesion in the nucleus, that's a lesion of the nucleus. You see that? So the entire nucleus is damaged. All those things are cut. When they are cut, what's going to happen? The lower part of the face is cut. Is that clear, folks? Upper part of the face will be cut, but then you have the second fiber, it will still innervate the upper half. Is that crystal clear, folks? So when you see a patient, if entire half is gone, that's lower motor lesion. Only lower half is gone, that's upper motor lesion, because your upper part is still in working, because the same side fiber is still innervating. Is that clear, folks? Now they're nicely shown here. Look at this. The upper part is cut. You still have the same site, nuclear stimulation. So even one is cut, the other one is still helping. Is everybody clear, folks? Now, this becomes very difficult after you remember. Simply, I tell the people, you don't have to worry about how many nerves and all these things. When you read a question, your task is to pick up, is it entire half of the face is involved or only the half of the half is involved? Does that make sense, folks? Once you pick up, you know what's the problem. That's all you need to know. Okay. Now, let's take a look. Please don't read the book. I want you to look at this lady. Look at this lady. We will separate her face. And we're going to say this. This is her right side, and this is her left side. First, type me which side of the face is even a problem. Which side is problematic? I'm waiting for that one person. I think I found that one person of you guys. Oh no, two people. Okay. Right side is function normally here, folks. Okay. Right side is functioning normal. This lady is trying to smile. Right side is smiling nicely. The left side is not pulling. Is that clear, folks? Think about, guys, when you smile, the cheek moves away, right? The right side cheek is moving. That means the muscle is contracting. The left side is not. Is everybody clear, folks? So the pathology in this patient is left side. Okay, so the right side is perfect in here. How do I know it's perfect? She's able to wrinkle the forehead and she's contracting and smiling. Is everybody clear, folks? So the left side is completely gone. How do we check when the patient comes to facial nerve? When they do a physical exam, right, in internal medicine or family medicine, we ask them to smile, puff up your cheek, raise your eyebrow, all these cranial nerve testing we do, isn't it? There you go. Now I want you to know, so first, left side is the problem. Is everybody clear with that? Now I want you to tell me, in the left side, is it entire half is gone or only the upper half or lower half? Which one do you see? You could say full, half. Just type full or half. So I see the entire half is gone. How do I know she's not able to smile? I don't see the forehead fold. You see? What's the mechanism for the folding? Muscle contraction. Muscle contraction, right? Muscle contraction is the mechanism. And here she's not able to contract. So this is the entire half of the face, which we call lower motor lesion. Is everybody clear, folks? Now, if I were to alter this picture and I say this patient still has folding here, then you could tell it's upper motor lesion because only this area is affected. Is that clear, folks? Is everybody following me here? All right. That's all it is, folks. Ask yourself half or upper half or lower half, folks. Okay, that's the idea. So everybody clear with the facial nerve, folks? Anybody has any question? Okay, let's read. Bell's palsy is the most common cause of peripheral facial palsy, usually develop after infection, not always HSV. So many different things can cause. We give them steroid and acyclovir. Most patients gradually recover function. Okay. Other causes of peripheral facial palsy include Lyme disease. I would highlight that. Remember, I mentioned this when we did the Lyme disease, right? Where did we talk about Lyme disease? Third degree heart block, AV nodal block. Third degree AV nodal block, right? All right. Herpes zoster also can cause, sarcoidosis can cause, tumor can cause, diabetes can cause. So many things can cause, folks, okay? Facial nerve palsy. Now we divide it into upper and lower. The key to learn, lower entire half, the whole half, folks. And upper mean only lower half. Is everybody clear? If you keep it like that, you would not have any issues, okay? That's the most important. Let's see.